My dear friends, my topic today is beyond glucose lowering. When do GLP agonists become cardiovascular drugs? When SGLT2 inhibitors first came into the market, they were blood sugar reducing drugs. But now they are heart failure drugs, they are renal failure drugs. Nephrologists and cardiologists use more SGLT2 inhibitors than diabetologists. Are GLP-1 agonists going the same way? Let us see. Well, the concept of glucagon-like peptide came in the early 20th century when it was found that intestinal extracts could lower blood glucose. But it was only very late, 1986, that Hebener and Mauzo could identify this protein, that is the glucagon-like peptide one. It acts on all types of pancreatic cells, alpha, beta, delta, and alpha cells, increasing insulin and somatostatin secretion and suppressing glucagon levels, and thus improves glycemic control. So the primary aim while the drug is given is to reduce blood sugar levels. But the story does not stop there. It acts on the central nervous system, reducing appetite, thus leading to reduction in obesity, reduction in adiposity. And as you know, adipose tissue is one of the organs which produces a lot of inflammatory mediators, and so naturally it reduces inflammation, and finally, of course, reduces weight loss. It acts on the liver metabolism, liver lipid metabolism, and by reducing hepatic steatosis and circulating lipid levels. It acts on the kidney. Data has shown that it reduces albuminuria and slows the decline in GFR. And last but not least, it also acts on the heart. It lowers blood pressure, improves microvascular and coronary blood flow, stabilizes the plaque, possibly by reducing inflammation. That is probably the most important thing, reducing inflammation and attenuating cardiac apoptosis. And GLP-1 receptors are there in the myocardium and vascular endothelium. It is not just pancreas, the heart also contains these receptors. Well, we still do not know what is the implication of it, but it is there. The problem with endogenous GLP-1 is that it is immediately degraded by DPP-4, so that its half-life is only a minute or two, and if you are giving that, you may have to give it as a continuous infusion. So that is the advantage of this GLP-1 receptor agonists, which mimic the action of endogenous GLP-1, but at the same time are not degraded by DPP-4, ensuring thereby they act long. So that is the difference between the pharmacological medicine and the endogenous GLP-1. So let me come to GLP-1 receptor agonists. Well, primarily diabetic drugs, so indisputable metabolic benefits in type 2 diabetes. And the second most important effect is obesity management, reduction in body weight. But as an offshoot, probably, there are beneficial effects within the cardiovascular system, consistently demonstrated, trial after trial, demonstrated significant reduction in the 4-point MACE, non-fatal stroke, non-fatal MI, cardiovascular mortality. But in these two groups of patients, either diabetes or obese, diabetes is not essential. In non-diabetic also there is data. But obesity is essential. As of today, we don't have any trial in non-obese individuals. Then heart failure with preserved ejection fraction, Jabir also already said about the problems. Well, there are therapeutic benefits in heart failure with preserved ejection fraction. Again, remember, independent of the diabetic status. A word about obesity, because that is where everything acts. The GLP-1 receptor agonists act basically there. 2/3 of obesity-related excess mortality are due to cardiovascular system. So the most important cause of morbidity and mortality in obesity is cardiovascular diseases. It has a direct relation, lot of data showing a direct relation between various diseases, cardiovascular diseases, atherosclerotic disease, heart failure, thromboembolic disease, arrhythmias, sudden cardiac death, even sclerotic aortic valve disease, aortic stenosis. And it also contributes to risk factors, hypertension, diabetes, dyslipidemia, OSA. So close link between obesity and cardiovascular disease, in addition to probably direct adverse effects on cardiac structure and function, again, possibly mediated by inflammation, the adipose tissue releasing inflammatory cytokines. So maybe everything finally boils down to inflammation. And now we have data also that epicardial adipose tissue, that is the adipose tissue seen around the heart, is a very active endocrine organ and releases a lot of inflammatory cytokines and fatty acid. Moreover, anatomically, mechanically, it is a load on the myocardium. Myocardial remodeling happens and it leads to myocardial fat content and interstitial fibrosis, leading to both diastolic and systolic dysfunction of the myocardium. And now we have data that GLP-1 receptors agonists probably reduce the EAT thickness also. Let us come to the CVS effects. Reduction in MACE, as I said, is independent of diabetes, possibly independent of weight loss also. There are preclinical data that GLP-1 receptor agonists produce anti-inflammatory and anti-atherogenic, and the atherogenic is also possibly related to the anti-inflammatory action. And meta-analysis of several trials have shown a good 12 to 14% reduction in MACE in patients with diabetes and established CVD, and I said data is also there for non-diabetic patients. The SELECT trial, for example, with semaglutide, large number of patients, obese patients, but no diabetes. No diabetes, remember that. It is off diabetes, but obese. The effect became apparent within the first 6 months before the peak weight loss was achieved, questioning whether is it weight independent also. We know it is diabetes independent. Is it weight independent is a question we do not know. And in heart failure with preserved ejection fraction, Jabir already showed 2 pillars, SGLT2 inhibitors and finerenone. Probably in the days to come, GLP-1 receptor agonists will become the 3rd pillar in heart failure with preserved ejection fraction. STEP heart failure with preserved ejection fraction with semaglutide was not diabetics, and we also had STEP heart failure, preserved ejection fraction, diabetes, where diabetic patients were studied for a year, and good weight loss, good quality of life improvement, improvement in 6-minute walk distance also. 43.5% reduction in hsCRP, suggesting the anti-inflammatory effect. Again, the question is the anti-inflammatory effect a direct effect of GLP-1 agonist, or is it due to reduction in obesity and reduction in the adipose tissue? We really do not know. Half as many serious adverse in the intervention arm than the placebo. FLOW trial with respect to kidney, patients with CKD, semaglutide, reduction of major kidney events, kidney failure, 24% reduction in death from kidney or CV causes. So even though a CKD trial, there was a bonus, cardiovascular death also reduced. Secondary outcome all significantly reduced. So there is data on reduction in CKD also. Coming to heart failure with preserved ejection fraction, again, because it is very important, it is now a significant challenge in modern medicine with increasing prevalence. And the basic problem in heart failure with preserved ejection fraction is diastolic dysfunction and the pro-inflammatory milieu. High prevalence of comorbidities like diabetes, obesity, and aging, and all of them contributing to systemic inflammation. JACC had written a review article regarding inflammation and heart failure with preserved ejection fraction. And this systemic inflammation provides a pivotal role in the pathogenesis and progression of heart failure with preserved ejection fraction. There are several phenotypes of heart failure with preserved ejection fraction, of which the worst prognosis is the metabolic phenotype, where the patient is obese, plus minus diabetes, definitely insulin resistant. These have a 4-fold increased mortality risk, and underscores the pivotal role of obesity and diabetes. So these two forms the crux of the metabolic phenotype of heart failure with preserved ejection fraction. So to sum up, GLP-1 receptors act in heart failure with preserved ejection fraction through 3 pathways: diabetes, obesity, and inflammatory response. Diabetes reduce HbA1c, reduce body weight, reduce epicardial adipose tissue, and reduce inflammatory biomarkers, all of them leading to reduction of inflammation, stabilization of the plaque, and improvement in diastolic dysfunction. What about combining SGLT2 inhibitors and GLP-1 receptor? There are no large randomized control trials. This is a cohort study of 30,000 patients, some of whom received only GLP-1 and the others with semaglutide. And the results were very good: reduction in heart failure exacerbation, all-cause mortality and hospitalization, and lower risk of atrial fibrillation, pulmonary artery hypertension, and renal injury. But remember that this combination is very dangerous if there is an underlying diabetic retinopathy, because the sudden change in blood sugar can lead to worsening of diabetic retinopathy. So you have to have a baseline retinal screening and gradual glycemic control rather than sudden glycemic control. But anyhow, this cohort study suggests synergistic benefits between SGLT2 inhibitors and GLP-1 agonists. A word about the new molecule, tirzepatide, which is a dual blocker, GLP-1 and GIP, and the SURPASS-4 trial showed reduction in MACE to 0.5, a risk hazard ratio of 0.5, which means about 50% reduction in event rate. And the heart failure with preserved ejection fraction trial, all-cause summit, all-cause mortality, worsening heart failure events significantly reduced, worsening heart failure requiring hospitalization significantly reduced. While semaglutide improved symptoms, functional capacity and weight loss, there was no reduction in hospitalization or mortality, whereas tirzepatide shows significant reduction in CV death and worsening heart failure, probably suggesting that there is a broader cardioprotective effect. Unfortunately, heart failure with reduced ejection fraction has not been very successful. Increased heart rate, some signals about fluid retention. So the benefits of GLP-1 reduction are multifaceted: anti-atherogenic, endothelial improvement, reduction in body weight, and anti-inflammatory action. And if you look at the CV endpoints, you can see most of the trials show benefit. You look at the meta-analysis, 3-point MACE, myocardial infarction, stroke, death, all of them significantly reduced by GLP-1. And look at patients who do not have diabetes, the SELECT trial, again, significant benefits. Renal endpoints, the gray bar is the placebo and the colored bars are GLP-1 receptor agonists. Uniformly reduction in the renal endpoints also. To sum up, ladies and gentlemen, SGLT2 inhibitors have shown benefit in all these multifaceted diseases, from diabetes, ASCVD, CKD, heart failure, peripheral vascular disease to obstructive sleep apnea and osteoarthritis of the knee. Even the newer drug tirzepatide has shown significant benefit in diabetes and ASCVD, obesity and prediabetes, and heart failure with preserved ejection fraction, MASLD and OAC. So we have more data coming, by the way. So coming back to the original question which I asked, are GLP-1 receptor agonists going the SGLT2 inhibitor way? Are they going to become cardiovascular drugs? Well, I don't know. Maybe we have to keep our fingers crossed, because everything could be due to obesity, in which case it is going to end up as an anti-obesity drug, not as a cardiovascular drug. We will have to wait for more data. It is this question which is very important, which continues to be unclear, whether the protective effects of specific organs result from direct receptor activation or indirectly driven by weight loss, because weight loss can do magic. It can affect all organs, all systems. So is everything due to weight loss? In which case, as I said, this will end up as a weight loss drug now, and the benefits subsequently of weight loss to the cardiovascular system, but not possibly as a cardiovascular drug. Thank you.
If we look into the data, the GLP-1 receptor antagonists and the tirzepatide data, the cardiovascular benefits appears earlier than their weight loss, because the weight loss appears later. Cardiovascular benefit appears earlier. So is it a pointer towards the fact that rather than the weight loss, of course weight loss contributes to it, the weight loss itself is predominantly anti-inflammatory, or it has another anti-inflammatory effect, which, because now obesity is considered to be a multi-system disorder, a disease, rather than a behavioral abnormality.
As I said, let's keep the fingers crossed. Let more data come. As at present, maybe there is some anti-inflammatory, beyond obesity. As of now, we don't have any trials in people who are not obese. That is the problem. We have trials in people who are not diabetic, but not people who are not obese. And to my knowledge, there is no such trial going on also. That is the problem.
Dr. Unni, I think the market is going to be flooded with semaglutide. One issue is there, it's NAION, which happens in 1 in 10,000 patients. So, how you go about it? Whether we should, and people with small optic disease more prone for this NAION.
See, every good thing will have a cost also. So that is the cost you have to pay. As I said, in the cohort study where they combined SGLT2 inhibitor with GLP-1 receptor agonist, there is some signal that it is the rapid control of blood sugar that is creating problem. So maybe you have to go slow with respect to control of blood sugar, and definitely a retinal screening may be worthwhile in all these patients.
Between the semaglutide and the tirzepatide, which one?
There is no data.
Less,
there is
less?
no data. There is no data.
Okay.
There is no data.
So, the worsening of retinopathy, is it permanent or temporary?
I really have no idea whether it is permanent or temporary, because the data has not continued. We have to wait for it.
Google,
Sir, regarding that thing, usually First of all, when you are going to prescribe a patient on GLP-1, you should have a 5-point checklist in your mind. First of all, you should meet the indication, whether the patient is having BMI more or diabetes is there. When the indications are ticked out, the second thing, you should go for contraindications. What are the contraindications? Whether the patient is having any history of thyroid cancer, particularly medullary thyroid cancer, which is pretty rare in our scenario. Second thing, the patient is having any history of pancreatitis. So with these contraindications, the drug is out of the picture. The third thing is that the warnings, the red flags that has been raised by the Australian medical agency, that there is the increased suicidal risk is there. It's only there, it's not yet proven, but always when you go for starting this drug, ask the patient whether the patient is having any psychiatric disorders or depression episodes prior to that, or whether they had a history of any suicide attempt. If so, be careful, go for a psychiatric opinion prior to starting this drug. And second thing, you should ask whether the patient had any history of diabetes affecting their eyes. If they are telling you that they had undergone a laser treatment, be careful. I always do that when the patient is having a severe PDR, severe proliferated diabetic retinopathy, or severe NPDR or PDR. In both these scenarios, it is better not to initiate quickly in these patients, because there is a high chance the patient's retinopathy will worsen. So always you can document the level of diabetic retinopathy, and whether the patient is having severe and PDR, then you should be careful. It's better not to go and initiate quickly in that patient, or go with a sort of slower initiation. And whether it is permanent or not, I would rather say it is not like even when you initiate insulin, this kind of worsening can occur. But we are still continuing with insulin. We are not going to stop insulin just because PDR is worsening. We should take the all-round picture of the patient, whether the benefit is overcoming the risk. In that case scenario, we can of course continue with this. But the patient is having a history of NION, noradrenergic ischemic optic neuropathy, then you should definitely stop this. It is contraindicated, and we better look out for MLCs. So in those cases where the patient is having NION, say if a patient had a history of NION in one eye, right eye, you shouldn't initiate the patient because he can have NION in the other eye also. So we should take all these checklists into mind. And another thing is that sometimes the patient is having a severe long duration diabetes which is uncontrolled, that he may be having gastroparesis and constipation. So whenever you initiate the patient on this drug, you should always ask them whether they are already having early satiety and constipation. These are also going to worsen with this drug. So in that cases, you should be careful and be ready with a prokinetidatic drug and a symptomatic treatment for constipation if that is bound to occur. And mark my words, some patients may develop diarrhea also. In that case also, we should always be careful and ask the patient the GI symptoms up to what extent they are having. So always keep this checklist in mind while initiating this drug. And as Sarah has mentioned, in detail, the cardiovascular benefits are all around there. And this drug is, depending on the rate it is going, it is bound to become like DAPA. Every other day we are going to prescribe this once the financial burden comes down.
Like SGLT inhibitors, where the dreaded urogenital complications are seen only or maximum in diabetic patients, and hardly ever in non-diabetic patient. This retinopathy also is not seen in non-diabetic patients. So you can see very confidently heart failure with preserved ejection fraction, if he is not a diabetic, you can very confidently give that. Same way the SGLT2 inhibitors.
Sir, as semaglutide is going to be off-patented, any data of safety of using semaglutide in post-MI situations where a patient is obese?
In an acute MI situation, I don't think there is any data. But most of the data that I have presented are patients who have established ASCVD. So that should not make any difference. In fact, the benefits will be more in ASCVD. But acute MI, I don't know.
In the trials, they have initiated this drug after post-MI, 3 months after post-MI.
That is what, not in
so
an acute
So it is better always don't initiate this drug in an acute scenario when the patient is in ICU, whether it is for any other indication. It's better you wait, because this drug is bound to have other side effects. It may be coinciding with the already patient's worsened scenario.
In post-MI situations only, it's better to start
post-MI and whether it is post-MI, post-CVA, post-peripheral artery disease or any vascular event, always go for starting this scenario once the patient settles. The trials, they have taken it as 3 months in the major trials.
If there is no further questions, thank you, sir, for the excellent talk.
Thank you, Sajju Francis.